on share content. Yay. Maybe no. Is it only going to share it if I do a PowerPoint? What? That's not right. I know we do. We need Rodney. Rodney, can you hear me? This morning he literally came when I conjured him with my mind. Will the screen, does it have to be in PowerPoint or will the screen, did I just not hit it? I thought okay, I'm punked now. We're on lab 3, right? Okay, so I didn't have time to I didn't have time to put this together next to the slides, but I have some pictures of cross sections of wet specimens that maybe will look similar to you that I thought we would look at real quick. I didn't grab what I meant to grab though. Darn it. All right, I'll probably have to do it for tomorrow. But so do you guys see that do these wet specimens look kind of familiar? You can see how little they are, right? There's so here's the pyramids, here's the olive right here, here's inferior cerebellar peduncle. There's that little dot. Remember that little thing in the tegmentum? It's actually the solitary tract, but that's okay. And then, let's see, I need to do, here you can see that the middle cerebellar peduncle has been cut off, right? You can actually see the cut. It's not just a cropped image. This is the trigeminal nerve right here. I realized I totally grabbed the wrong specimens. So what is this part?
Basilar pons.
That's the basilar pons, okay? And so the basilar pons is, in terms of kind of general region of the brainstem, that's part of the basis, right? Because it's got, you can see the fascicles of the corticospinal, and the corticobulbar tract is in there too, in that ventral surface. And then, let's see, we didn't learn that one. But you see these two sections? Right? So what is this one right here? Yep, this is the cerebral aqueduct. This is the cerebral aqueduct. So what part of the brainstem is this? Generally, so tell me, let's just orient to whether it's medulla, pons, or midbrain. So this is midbrain, okay? So this is caudal midbrain, and this is rostral midbrain. So do you see, what is the structure in the middle of the bottom of the midbrain? Nope. So here's red nucleus. You said red nucleus, so this one got pinned at one point. So here's red nucleus. Here's red nucleus. There's a midline structure that is a yelling anime robot mouth.
Oh, the superior cerebellar desiccation?
Decussation of the superior cerebellar peduncle. So that's right here. You can kind of see these two right next to each other. And what I think is cool is, look, they're with the cerebellum still attached. So this is this is anatomical orientation, sorry. So do you see the relationship of the midbrain? And look, there's a basilar artery. There's the pons right there. This is red nucleus. That's actually the Edinger-West, or the ocular motor nucleus is right there. Oh my gosh. And then there's the, what is that hole? Cerebral aqueduct. And then, so there's the hole right there. And then there is where the decussation of the The SCP is, and what's this little guy right here? That'd be the trochlear nerve coming off the back of the brainstem. Okay, so I remembered what I actually wanted to show you was some sections through the pons and the cerebellum. So I'll pull those out and we'll look at those tomorrow. So now let's do some cases. Learning cases. Okay, so case 1. Did everybody get one? Doesn't look like it. One person did it. Oh. Oh, okay, good. Because this is easier for me. Oh man, why did I bring a bunch of sticks in here and leave them? Don't really know why. It's just a pile. Okay, so patient presentation. A 13-year-old boy comes to the pediatrician's office with a 2-month history of progressive left occipital headaches accompanied by nausea and vomiting and recent development of slurred speech and unsteadiness. A couple notes I'm going to tell you right here. 2-month history, does that sound like a vascular accident? Is a 13-year-old super likely to have a vascular accident? No, although my former student who's now a neurology resident did actually have an MCA stroke on like a 14-year-old, but he had a lot of other issues. So normally with a teenager, probably not thinking it's a stroke. Okay, so this was progressive. Also, where is he feeling his headaches? Left occipital lobe. Oftentimes, pain is a localizer. So what is back here in his left occipital part of his skull? He's got a cerebellum in there, right? So, okay. So the patient's headaches began 2 months ago, gradually worsened with pain mainly experienced in the left occipital area, and sometimes accompanied by nausea and vomiting, but no visual changes. So is it a migraine? I don't know. The headaches were worse at night and in the early morning hours. So that's another notable symptom. His teachers noticed that over the past few months he had had some difficulty concentrating and learning new material at school. During the week prior to presentation, his mother noted increasing gait instability, mildly slurred speech, and decided to lock up her liquor cabinet a little bit better. No, decided to bring him to the pediatrician. On exam, the boy was alert and oriented, and his speech was fluent. On cranial nerve testing, his pupils were equal, round, and reactive to light and accommodation. So what innervates the pupils? Ocular motor does, parasympathetic, and then the sympathetic is, how does the sympathetic work? So it dilates them. Where does it come from? So down in the thoracic spinal cord, and it's got that long, funny course up through there. But apparently that's okay. Let's see. His fundi, which are the retinal region opposite the lens, had blurred disc margins. We haven't really talked about that, but that's something called papilledema. So mild papilledema bilaterally. So the back of his eyeballs aren't looking quite right, even though his vision is intact. His extraocular movements were full, but he had horizontal and vertical nystagmus. And his vestibulo-ocular reflex was not fully suppressed by visual fixation. Interesting. His face was symmetrical. Facial sensation and corneal reflexes were intact, so that should already be telling you about parts of his brain that are okay. Hearing was intact to whisper bilaterally. He had normal palate movements. His gag reflex was intact. His sternocleidomastoid and trapezius strength were good. His tongue was midline. And when we checked out what was going on with his arms and legs and trunk, motor and sensory exams were normal. However, the patient had a wide-based gait with feet about 2 feet apart. He was unsteady and he staggered to the left. He was unable to perform tandem gait. So do you guys know what tandem gait is? Yeah, like walk with a line. Okay, so he couldn't walk with his feet together at all. And there was no worsening of his unsteadiness on the Romberg test. So he could not stand with his feet together even with his eyes open. His heel to shin movements were ataxic on the left and normal on the right. He had marked dysmetria, so lack of coordination on finger to nose testing, worse on the left with approximately 2 inches of error. So he was really missing his target. There was also dysdiadochokinesia. Whoa, that's a big word, isn't it? That just means rapid alternating movement. So when we ask him to go like this, can he do this as fast as you can? Can you do it? So he had some issues with that, and that was worse on the left side, and his speech was slightly slurred and had an irregular rate. Okay, so, that was a lot of stuff. So what is the clinical temporal profile of the pathology? So let's look at this patient. Is this acute and progressive? So like, is this a sudden onset kind of thing? Acute and stable, chronic and progressive?
Quick question.
Oh, yes.
On exam, the boy was alert, oriented, and his speech was fluent.
Uh-huh.
By the end of the exam, he had slurred speech.
Well, fluent means he can produce it. That okay. Fluent is referring to, does he have Broca's aphasia? Okay. And he doesn't have Broca's aphasia. He has no trouble. Like, he wants to say something, he just sounds like he's drunk when he says it. Okay, so let's see. We voted for. Did we mostly vote? Yes, we voted. All right, so this was indeed chronic and progressive. Okay, based on his history, what do we think is causing this pathology? Well, this is a chronic and progressive thing, and that sounds like there's probably something growing. Okay, and in childhood, the most common primary brain tumors, which a primary brain tumor is a brain tumor that starts in your brain. It doesn't metastasize from somewhere else. Mostly in a kid, this is typical that they would have an infratentorial lesion basically in the posterior fossa, where was his pain again? Okay, posterior fossa. Adults, it's like the exact opposite. They tend to have supratentorial lesions. All right, so papilledema, I said it was a big deal. We hadn't even talked about that. Man, not only do I make you learn a bunch of stuff, I make you learn a bunch of stuff I didn't even tell you about. So papilledema is a type of retinal change that when you do an ophthalmoscopic exam, you can see it. So let's just guess. We already are having an idea this is a tumor, right? So what do you guess is the significance of this bilateral papilledema? So this is a guess. Just guess. Just commit. Guess and commit. It doesn't matter if you're wrong. It matters if you try. Okay? All right, so we are mostly committed. Okay, so the answer is it's actually a sign of elevated intracranial pressure. So pat yourself on the back if you got it right. So what happens when you increase pressure in your cranium, it can push on the back of your eyeballs and it can squish your retina. Okay, so that is what you see on ophthalmoscopic exam. So you can actually tell that. Why is it not B? Well, because it's actually a sign of increased intracranial pressure. So it doesn't really matter where the mass is inside your skull that's causing the increased intracranial pressure. It could be any of those areas of the brain. They can all cause papilledema. Nystagmus is a sign of a vestibular lesion. It's not going to cause issues with the back of your retina. And then we'll talk about his slurred speech and unsteadiness in just a little bit. So this is what a normal retina looks like. So this is called the optic disc margin, and we'll talk about this more next week. This is where the retina, where basically the optic nerve leaves the retina, and it has a nice defined edge in a normal eye. But when you've got your brain pushing on the back of your retina, does that look good? It looks a little squishy, okay? So this is something that if you have like a acute bleed in your cranium, you're not going to see papilledema in your patient. This takes at least hours, probably more like days to develop. So this kid has, yes, sir?
Oh, sorry.
I was just say this has been ongoing for a couple months, right? This has been progressing.
You're saying we should just be attuned to the clarity of the margin of the disc?
Yeah. So this you can see kind of, like the blood vessels here versus the blood vessels.
It seems like they're almost bulging.
Yeah, and they kind of are because the back of the brain is like pushing on them. All right, so this patient actually has a bunch of signs of increased intracranial pressure. Big one is headache, but normally a headache caused by a mass inside your head? no. Like most of the time, it's not a tumor. But he's got headache in his left occipital area. So again, pain is a localizer. He does have altered mental status. His teachers are saying he's having trouble learning at school, like more so than is normal. He did have nausea and vomiting. He also had the papilledema. Didn't have the rest of that list, but he's got some pretty major signs that he's got something growing inside of his brain. Headaches that are worse, that are when he's lying down. So like when he lays down, his headache is worse. Well, who's had a sinus headache before? When is it worse? When your head is down. So basically when gravity is working against you, when gravity is causing more fluid in your skull, the headache gets worse. So that is another sign of increased intracranial pressure. So next question, does this patient have any long tract involvement? So does he have any motor or sensory symptoms in his body? Okay, so we have the actual answer to this is actually no. But you said, but wait, he's all uncoordinated. That was a terrible question, wasn't it? So what we need to differentiate here is, does he have issues? So the corticospinal tract is for strength and reflexes. And then, so when we're talking about body involvement in this case, does he have any long tract involvement? That's referring to strength and reflexes and sensation. So this is cerebellar stuff, right? It's also the day we're talking about the cerebellum. So this is probably something associated with the cerebellum, not with the long tract. So in terms of localizing our lesion, let's see, fine touch, proprioception, pain and temperature sensation was intact. The corticospinal tract is specifically for strength and reflexes, is what you would do to assess that function, and that was all fine. So, but there are three components to movement in the body. What component of volitional movement are we having trouble with here? Okay, so yes, agreed. So this would be coordination. Strength and reflexes is controlled by what? Corticospinal tract and the lower motor neurons, right? So both parts of the reflex. What thing controls the volitional part of movement? Does anybody remember the name? Oh, that's okay. So coordination is cerebellum. Volition is by structures that are part of the basal ganglia, which we will talk about next week. Does the patient have any cranial nerve involvement? Yes or no? Okay, so no, he does not. However, we'll talk about a possibility why he might, okay? So first of all, pupils round reactive tells you our parasympathetic and sympathetic is okay. Visual field's full, cranial nerve 2 is okay. Extraocular movement's full, 3, 4, and 6. Facial sensation intact, 5 is okay. Symmetrical, 7 is okay. Corneal reflex is, what are our two limbs? Afferent, efferent. Afferent is 5, efferent is 7. So confirm yes. Hearing intact to whisper. So the cochlear part of cranial nerve 8 is okay. Palate and gag 9 and 10 were fine. But he had nystagmus, right? That's what you want to say. But he's nystagmus. That doesn't, maybe his cranial nerve is not okay. Maybe 8 is not okay. Well, remember the thing about nystagmus, it doesn't tell us cranial nerve 8, it tells us vestibular system. So cranial nerve 8, his hearing is intact. 8 is probably okay. We were probably looking at some type of issue with the vestibular circuitry. So that could be vestibular apparatus, we're probably not it. Vestibular cochlear nerve, probably not. Vestibular nuclei, we're just not suggestive of a brainstem lesion at this point. But if we have a lesion of the cerebellar peduncles or of the vestibular part of the cerebellum, indeed we can have nystagmus. All right, and oh, I got out of order. Also, there's some more things that were okay. All right, so 11 was fine, 12 was fine too. And then just as a note, I think this is somewhere written down, but he did have vertical nystagmus, which is actually in terms of localizing, because nystagmus is little tiny eye movements that are not like, oh, this person obviously has horizontal nystagmus. This person has rotational nystagmus. Sometimes it's kind of hard to tell, but if you do see abnormal up and down movements, it is actually associated with a lesion of the cerebellum. All right, so what does the lack of body involvement and the lack of cranial nerve involvement indicate about where this lesion is, the location of the lesion? Okay, all right, so we're kind of all over the place here, but that's okay. This wasn't a super easy question because I gave you kind of confusing answers. However, the correct answer is D, lesion outside the brainstem. Why? Well, the brainstem is infratentorial. So when we're seeing involvement of the, like cranial nerve involvement plus involvement of the body, we kind of need to think brainstem. So that's infratentorial, that's not indicated here. Supratentorial lesion, it's just another option, nothing to see here, just, to throw you off, because I would never try and do that. Lesion, it's not a lesion inside the brainstem though, because we would probably see some long tract involvement or some cranial nerve involvement in a little different pattern. So the fact that he doesn't have, that his body in terms of long tract is not involved, and that he doesn't have any cranial nerve symptoms, we need to look outside of the medulla pons and midbrain. All right. Okay, so what is nystagmus? That is spontaneous abnormal eye movements that are damaged anywhere in the vestibular system. So again, it's not a great localizer because look at all this territory. There's a bunch of stuff in the brainstem that can cause it. You guys, okay, what are we looking at here? So the cerebellum, what did I do to the cerebellum? I chopped out the brainstem. So what is this cut surface of what right here? Middle cerebellar peduncle. What is this cut surface right here, do you think? Did I hear superior? What's top and what's bottom there? It's the inferior. So I'm gonna orient these. Top is up, bottom is down. So this is actually inferior cerebellar peduncle. Here's superior cerebellar peduncle. What is this right here, do you think? Nodulus. And then what is this little guy out here? Flocculus. And there's actually a little bit of vestibular cochlear nerve right there because those two systems are very closely intertwined. All right, so vertical nystagmus, like I said already, is actually a sign that is associated specifically with cerebellar dysfunction. All right, so inability to suppress the vestibulo-ocular reflex is associated with lesion to which part of the cerebellum? Okay, all right, so I think we're pretty good on that. Indeed, it is the flocculus. So the flocculus plus the nodulus are called the flocculonodular lobe because they kind of all work together. But it is specifically localizes more to the flocculi, that inability to suppress VOR. So what is VOR again is basically that my eyes will automatically oppose movement of my head unless I specifically have activation of the flocculus to say, hey, stop that. We want to move our eyes with our head, which actually, do you feel kind of like a drag? Like when you do that, like it's kind of like, okay, that took some effort, right? So that's like the feeling of the flocculi stopping VOR. Okay, so how do we test it? Put your arms out, focus on your thumbs, and rotate and keep focusing on your thumbs. So while your patient does that, you watch their eyes, and if the patient has any nystagmus while that's happening, that is a sign that they're having trouble suppressing VOR, which localizes to the flocculus. Okay?
So the eye will just stop moving, essentially?
It wouldn't. What usually will happen is that it'll instead of being like just a keeping fixation, you'll have little jerky nystagmus movements. As it will oppose and then it will kind of catch up, oppose and catch up. All right, so wide-based gait, inability to perform tandem gait, and no worsening of unsteadiness with the eyes closed, which was a Romberg test, are all indications of lesions to which part of the cerebellum? Okay, so this would actually be the vermis because those are all signs of truncal ataxia. And it's kind of like, the middle of the cerebellum controls the middle of your body. So again, this is actually kind of somatotopy at work here. So the center, the control of there's actually lots of motor systems that control your balance muscles, but they are all coordinated by the vermis. So if the vermis is not working, you are going to have to try and compensate basically intellectually by things like a wide-based gait, a wide-based stance, and then if you can't, those are just all signs of truncal ataxia. So let's see. Again, Romberg test. Are we feeling pretty good about the Romberg test? This makes sense, right? I talked about it in lecture. I forgot this was left over in here. So ask the patient to stand with their feet together, touching each other, then ask the patient to close their eyes, remain close at hand in case the patient really begins to sway or fall. So normally what keeps you stable with your feet together and your eyes open, your visual system gives you some sensory input about your relative location. Your joint proprioception gives you some sensory input about where your body is in space. Your vestibular system gives you some input about where you are relative to gravity. And then the vermis of the cerebellum organizes all of those output tracts that tell your motor nuclei and your spinal cord what to do without you really thinking about it. So normally when you then close your eyes and lose that visual input, there is a slight worsening of unsteadiness, but it is very slight. You certainly don't fall over normally. And that is when your cerebellum is intact. But so what this does is it helps you distinguish if somebody is having balance issues to distinguish sensory ataxia, there's such a thing. Mostly though is cerebellar ataxia. So what does that do? So no lesion, you're fine. But if you have a vestibular lesion, like we talked about the acoustic neuroma, like if we tested that patient who has an acoustic neuroma, when they close their eyes and lose that visual input, they are going to have a worsening of unsteadiness because they've got an issue with their vestibular input. Someone with Meniere's disease is also probably going to have a positive Romberg sign because one of those things that allow you to sense your balance aren't working properly. Proprioceptive lesion, next week we'll talk about spinal cord and where we bring in our proprioceptive information. This is also associated with a positive Romberg sign. So somebody with MS like we get some demyelination of that information coming in, might say, I'm having these sensory issues. You do have them do Romberg testing. You notice they're really swaying a lot more. Okay, maybe they've got some demyelination. Yes, ma'am?
Which one was the one where they just literally fall over? Or is that kind of 2 and 3? Is there one where they would just collapse?
Well, so all of these 3 are probably going to have some balance issues. These 2 are going to be worse when you close your eyes. This one, like that kid couldn't even stand with his feet together, right? So he's got some serious instability when he tries to stand with his feet together, but it doesn't make any difference whether his eyes are opened or closed, because if the cerebellum is no good, you can't coordinate if your cerebellum isn't working. So this ends up being no Romberg sign to tell you that this is a cerebellar lesion, versus a positive Romberg sign tells you it's a sensory issue, and your unsteadiness is a sensory issue. Okay, so again, it's an annoying way they do the terminology for the test, but that's our patient right there. So he had ataxia on left finger to nose testing and dysmetria, missing the target on left finger to nose testing are all indications of lesions to which part of the cerebellum? Okay, so this is actually asking 2 questions, right? So the correct answer is left intermediate hemisphere, because 1, this is asking you which part of the cerebellum takes care of moving your arms and legs, takes care of coordination of your appendages. And so it is those intermediate hemispheres. Coordinate your appendages. Lesion there will cause appendicular ataxia, which you test by having your patient move their arms and legs in what should be a smooth motion, a smooth and coordinated motion. And then the second part of this question is, what side of the cerebellum controls what side of the body? So cerebellar lesions, remember we said they were essentially, cerebellar system is essentially double crossed. So right cerebellum influences coordination in the right body, left cerebellum influences coordination in the left body. Okay, so again, here's the diagram from lecture. So ataxias are ipsilateral to the side of the lesion. Here's another little clue. When they say he's staggering to, was it to the left? I forget. The patient will usually fall toward the side of the lesion. So another clinical localization. Dysmetria then is abnormal over or undershoot pass pointing during movements towards the target. Dysdiadochokinesia, again, was that rapid abnormality of rapid alternating movements. Those are just signs of appendicular ataxia. Slurred speech with, yes, sir.
Can you have just, so if it's just an intermediate damage, would that also, that would affect the test on the vermis as well, right? You can't really have one without the other.
Sometimes you can, but it's only with like a tumor. So usually you're going to see these affected together. So slurred speech with an irregular rate is called ataxic speech. It's another indication of cerebellar dysfunction. But basically, anytime you hear the word drunk to describe someone's motions, and it's not because they've actually been drinking, you should think cerebellum. So alcohol intoxication very specifically impairs, it impairs decision-making cortex, but it also impairs cerebellar function, which all of those roadside tests, that can you walk on a line? That's a test for truncal ataxia. Can you touch your nose? That's a test for appendicular ataxia. Follow my finger. That's a test for nystagmus. So those are all, I don't even know if they know it, but they are testing cerebellar function on those roadside tests. So this patient's symptoms indicate damage to which of the following structures? Ooh, this is going to be tricky to hold your cards up. This is before I knew we were doing this way. And if it's E, you should get up and jump. Yeah. Oh, wait, maybe not. Okay, so I see people are choosing about 3 options. That's good. Oh, look, somebody made an E. All right, so that is correct. It is all 3 of the functional parts of the vermis. He's got truncal ataxia, appendicular ataxia, and inability. Oh, there you go. Nice job, Grant. No VOR suppression. So also a note, this kid probably has something growing in his brain. Again, we have to kind of step back and look at our patient. But when we talk about vascular lesions of the brainstem next week, we're going to end up losing vascular supply to those cerebellar peduncles. At that point, will we just get appendicular ataxia? No. At that once you have an issue with all of the inputs or the outputs from the cerebellum, you just get ipsilateral ataxia of all kinds. All right, so lateral medullary syndrome, lateral pontine syndrome, superior cerebellar artery, I said, was the one that if you just have sudden onset of ataxia, that's probably the artery that's at fault. Yes, sir?
And it's ipsilateral because it decussates twice?
Because the cerebellum the right cerebellum influences the left cortex, and the left cortex controls the right body.
Makes it seem like it's cool.
Is that good? Okay. Because there is actually, you can have a midbrain lesion that causes contralateral ataxia.
Of course you can.
But we're not going to talk about that. Yes, ma'am.
If we're talking about truncal ataxia, though, does it matter that it's ipsilateral?
No. The appendicular is what matters. The appendicular will be on the side of the lesion.
Okay, so basically, if there's anything to do truncal ataxia, it's just going to be the whole.
Yeah. All right, so chronic or progressive ataxia, posterior fossa tumor is right in line. So here is the MRI, and which side is up? Okay, so do we see the guy's up is up? So here's his nose. Oh yeah, I said that wrong. Here's his nose. Do you see his little eyeballs right there? Here's some temporal lobe actually. Here we're back here in the posterior fossa. Do we see some things that look slightly amiss to us? Okay, how about the giant tumor? Is this what your 4th ventricle is supposed to look like? And it's at least supposed to be midline, if nothing else. Small, fine. Midline, this is way shifted up midline. Look at this guy's little pons right there. Does that look squished to you? Yeah. So doesn't it seem like he should have more trouble than he does? But he's a kid. Kids' brains are quite amazing. Also, this has developed slow enough that, again, the nervous system can do, the younger you are and the slower something grows, the longer it takes for you to see symptoms, which we see in this kid. Yes,
Was that an MRI or a CT?
This is an MRI. And how you tell is look at the skin. And so CT is an X-ray, so bone. We would just see bone. We would see really thick bone versus an MRI is imaging protons, so water is one of the things that really shows up. So we've got fat, and then this is one layer of bone, the hard bone. There's the diploe, and then there's the hard bone. So that's kind of your visual, which we're actually that's in one of your handouts next week. But now you know it, so you're good. Then if we go up, and here's a section up through the brain, and these are ventricles. And remember, so here's balls in the middle of the brain, balls in the middle of the brain. The 3rd ventricle is supposed to be a slit-like ventricle. Do we see that is pretty big, not very slit-like? An older person can have a ventricle that looks a little bit more like this, but this is parts of the lateral ventricle. This is way too big. So this kid is having some obstruction of cerebrospinal fluid. It's getting stuck up above in his cortex. And so do you see why maybe his brain is pushing on the back of his eyeballs? Because we've just got too much volume inside our skull. So when he lays down, you can see how that would make his headache worse. All right, so he's got hydrocephalus. So final diagnosis, it was actually an astrocytoma. I don't know anything about that because I'm not a pathologist. Of the vermis and the left cerebellar hemisphere causing hydrocephalus. they were able to take the tumor out, and even as big as that thing was, he was left with a little ataxia, but was still pretty much okay. So there you go. This is from the Blumenfeld test. Yes, sir?
And why the nausea and vomiting? Was that just because it's already
Increased intracranial pressure.
Okay.
That's one of those big signs of increased intracranial pressure. Also, or it could be disorder of the vestibular system, but this is really more cerebellum, so it probably had more to do with the increased intracranial pressure.
Squeeze them on the brain. You could expect to see those.
Not anytime, but it is definitely high on the list.
Concussions.
Concussion, yeah, can cause nausea and vomiting. Absolutely. All right, good. Any more questions? That was. You guys knew that was cerebellum right off, right? Sure.
Sure.
Okay, next case. This one's a little shorter. 76-year-old man with a history of cigarette smoking developed progressive difficulty walking over the course of a month. Okay, does that sound like a vascular lesion? No, okay. He noticed that when he stood up, he felt woozy, and he described his gait as feeling like he was drunk, saying, "My legs go one way and I go another." His family said he frequently lost his balance with staggering and unsteadiness. He also had frequent mild headaches that occurred at any time of the day and night, but seemed to be getting worse. Exam was unremarkable except for a wide-based, unsteady gait, tending to fall to the left, especially with tandem walking. Of note, there was no ataxia on finger to nose or heel to shin testing, and no dysdiadochokinesia. Okay. So back to looking at our patient, what's the clinical temporal profile of this guy? So he was a smoker. I bet he probably had some vascular risk factors, but does this sound like a vascular accident? No, it does not. So you are correct, chronic and progressive. So in adults, most of the primary tumors are actually above the cerebellar tentorium versus what we just saw with the kids. Secondary, wait a second, he was a smoker, wasn't he? Okay, so secondary metastatic tumors are more common than primary brain tumors. So in adults, this is kind of the order. This is nothing you need to memorize at all. This is just for your information. But a site of a metastatic tumor is going to follow the blood flow, which that kind of makes sense. So this guy, he had a history of smoking, and he also, we can get a metastasis to the cerebellum is possible. So this is just a kind of some information about how this pathology works. So what type of ataxia does this patient have? Okay, so get our votes in. Okay, so we are mostly correct, not all correct. This patient had truncal ataxia. This patient actually specifically did not have appendicular ataxia. So what part of the cerebellum is associated with truncal ataxia? Okay, so, all right, sounds good. Yes, the vermis is associated with truncal ataxia. So right intermediate hemisphere would cause right appendicular ataxia. Left intermediate hemisphere would cause left appendicular ataxia. Flocculus, we'd have an inability to suppress VOR. We didn't mention it, so we're going to assume it's not there. So associated with lesion to the vermis, because that is coordinating all of the medial motor systems. And then again, if you hear the word drunk, you should kind of think cerebellum. So we didn't test it, but would this patient have a positive Romberg sign? Yes or no? So Romberg is worsening of unsteadiness with eyes closed versus eyes open. So would he get worse? Is this a sensory ataxia? Okay, most people agree with me that he would not have a positive Romberg sign because he can't do it with his eyes open or his eyes shut because the problem is the cerebellum. Okay, so that's a no. So what would we expect to see on ophthalmoscopic exam? Do you think this guy would probably have some papilledema? This has been going on for a couple months, or like a month, I think it said. So it's been long enough. It's very possible he might have papilledema. So here's another picture showing kind of sharp margins versus blurring at the margins, just a diagram. Significance of his headache. A dull, constant headache is actually associated with neoplasm. This guy, I don't know, like maybe I wouldn't be like, oh yeah, his headaches, he definitely has a brain tumor. It's consistent, but it is not necessarily indicative of his pathology. All right, so here's a CT. Do we see that this is a CT? So here we see bone, and then this is kind of what the skin looks like out here. So here's a CT, lots of resolution of bony structures. Here's posterior fossa. Do you see how the brain, it's not as easy to tell what the brain looks like on CT at all, is it? But here is where he has a mass in his cerebellum. Here's, if I go back, you see the fourth ventricle is just this little tiny thing right here. Here's the pons. So there's his mass in his cerebellum, and it actually is enough localized to the cerebellum that it's actually, to the vermis, that it's actually sparing the hemispheres. So he ended up with just truncal ataxia. So he had no issues on finger to nose testing, no issues on heel to shin testing. He could do the rapid alternating movements, the dystatico. He had no dystaticokinesia. He could do that just fine. All right, so he did have metastatic carcinoma of the cerebellar vermis. They treated him with radiation therapy and steroids, and then 4 months later, he still had gait difficulties and the lesion was bigger, so went ahead and did some surgery, and he did seem to recover. All right, next case, a 41-year-old woman was referred to an otolaryngologist, that was hard to say, for dizziness and progressive hearing loss in her left ear. She began to have episodes of mild dizziness about a year ago. So does this sound like a vascular lesion? It doesn't, does it? 2 months ago, she noticed impaired hearing in her left ear, severe enough she couldn't use her phone on that side. She also had some left facial pain. On exam, she was alert and oriented, ×3, which again indicates to who she is, to when it is, to where she is. Her pupils were round and reactive to light. Her visual fields were full, and her extraocular movements were intact. So top of the brainstem is looking pretty good. Face was symmetrical, and facial sensation was intact to light touch, but she did exhibit a decreased corneal reflex on the left. Hearing was severely impaired in the left ear. A vibrating tuning fork sounded louder when held just outside the left ear than when the handle was touched to the left mastoid process. We'll have to talk about that. Voice and palate elevation was normal. Sternocleidomastoid strength was normal, and her tongue was midline. She had normal strength and reflexes in her extremities, and coordination was normal on finger to nose and heel to shin testing. She had intact pinprick, vibration, and joint position sense in her extremities. All right, so what about her? Clinical temporal profile. Is this, man, we keep all of these today, isn't it? They are all, you're right, they've been going on for a while, and they all seem to be getting worse, do they not? So that is suggestive of something growing inside your head. So the patient's primary symptom was, what was her biggest issue? She couldn't talk on her phone in that ear, right? So which test did the examiner use to assess her hearing based on what it said? So the test said hearing was, a vibrating tuning fork sounded louder when held just outside the left ear than when the handle was touched to the left mastoid process. So which test was that? Okay. Yep, so that's the RIN or the Rene test, depending on how fancy you want to be. So what did that test tell you? What type of hearing loss was in that ear? It was sensory neural. So if it had been conductive, it would have been better when they held the tuning fork on her bone, but it was still better through the air than through bone, which is a sensory neural hearing loss profile. Okay? Oh, look at that. I already answered our question. Whoops. Sorry. So you all get it right. It's A. It's sensory neural hearing loss. Okay. So jumped my gun there a little bit. Does she have any long tract involvement? So does she have issues with strength and reflexes, or does she have any sensory symptoms in her body? Yeah, we specifically said no. Is the last line or one of the last lines of there. So her strength and reflexes were intact, which tells us her corticospinal tract and her lower motor neurons in her spinal cord are okay. And then the sensory systems bringing in somatosensation are also spared. So does the patient have any cranial nerve involvement? Yes or no?
So Dr. Derringer, with the previous one, by body, you mean anything outside the head?
Mm-hmm. Yeah. And it's basically, we haven't really talked long tracks yet, so we've just mentioned them because I'm actually, you guys are an experiment. Do you know that normally I teach the long tracks first? But I switched it up. And I'm curious how it's going to work. So, let's see. We said yes. And yes is indeed correct answer. All right. So, what's good? Again, they told us a lot of things are good. So, for pupils, sympathetic, parasympathetic innervation is okay. Visual fields full is cranial nerve 2. Extraocular movements full, 3, 4, and 6. Facial sensation was intact. And her face was symmetrical. But wait a second. She did have an issue with her corneal reflex, didn't she? So her facial sensation is okay, but like somehow her corneal reflex is messed up. Her face is symmetrical. Okay, so we need to keep that in mind. We need to be suspicious of 5 and 7 at this point. She did have the sensory neural hearing loss, so where does that localize to? Either the cochlea or the vestibular cochlear nerve. So those are, palate and gag was okay, so 9 and 10. Sternocleidomastoid trapezius, head turn, shoulder shrug, 11 was okay, tongue was midline, 12 was okay. So we've got something, definitely 8, and then 5 and 7 we need to be suspicious. So how do we explain that? Well, the examiner, it actually maybe just tested light touch. So remember, there are 2 components to sensation. There's fine touch and proprioception and pain and temperature sensation, both for the body and for the face. The face, pain and temperature is spinal trigeminal nucleus. Fine touch is that chief, did I call it chief or did I call it principal? I can't remember. Okay, good. Chief sensory nucleus, because usually I say all of them with medical students because they hear it from like 5 different people. All right, so the patient did say facial pain, right? Didn't she say something about facial pain? So probably what's happening is there's some type of dysfunction with her trigeminal nerve that is, maybe her fine touch is intact, but maybe she's having some issues with pain sensation. So that it is probably an afferent issue with her corneal reflex. So, but what is the fact that she has no body involvement, and even that reflex was on the same side as her hearing loss? What does that tell us about the location of the lesion? Okay, so we have some commitment. We're close. So this is kind of like yesterday. This is probably a lesion. We didn't affect our long tracts at all, and the cranial nerves we did affect were on the same side. So we're probably looking at some type of lesion outside of the brainstem. So no body involvement plus all same-sided cranial nerve symptoms is suggestive of a lesion outside of the brainstem. So given what we know that can affect the vestibular cochlear nerve, and given the time course and the symptoms, which of the following is the most likely pathology? I like it. Okay, so we're not feeling strong on this, are we? Okay. All right, so this is those who went for E. You were right. Yay, for the win. It's an acoustic neuroma. Okay, so why was it not an aortic infarct? Well, a vascular lesion of the brainstem. Was this a vascular onset? No, this wasn't a stroke. So that's not it. Jugular Foramen syndrome, we talked about yesterday. What nerve should have been affected if this was jugular Foramen syndrome? And did we have a problem with? No, we did not. What about Meniere's disease? I saw some choices. Some people, this kind of spoke to them. Why not Meniere's disease? So there's definitely hearing loss in that. That's the increased endolymph, increased production of endolymph. Well, what else should you have with Meniere's disease? You should have, I couldn't actually understand the word you said, Chris, I'm sorry. But you should have some pretty serious vertigo with Meniere's disease. Was she complaining of vertigo at all? No, the vestibular division of the vestibular cochlear nerve, we didn't hear a word about that, really. I mean, a little unsteadiness, but...
What about the mild dizziness?
So she had some mild dizziness. So that, maybe there's a little vestibular effect, but with Meniere's disease, it is pretty debilitating. Okay, what about the benign positional paroxysmal vertigo, the BPPV? Does that have hearing loss associated with it? That has what? Just vestibular, just vertigo. And that also depends, did she, well, it was hearing, it wasn't vertigo. So the BPPV doesn't have hearing loss, and the vertigo is triggered by certain positions. So acoustic neuroma is what we're looking at. Remember, this is a tumor, which fits our profile. It grows on the vestibular cochlear nerve at the internal auditory meatus, where we hand off oligodendrocytes, say, okay, Schwann cells, take it away for myelination. So here's vestibular cochlear nerve on this brainstem. What's this little structure right here? That's right, flocculus. Can we see the nodulus here? No, because we'd have to cut the brainstem off. Did you have a question?
Yeah, I have a question. On the corneal reflex, how do we distinguish between it being 5 and 7, especially if there is hearing involved? Because that would affect the stapedius, and so wouldn't that be a louder hearing?
That's not going to cause
Right. So if she has hearing with that, doesn't she have louder?
But words, okay, so you're conflating two things a little bit.
Okay.
So corneal reflex is just testing, do we have sensation on our cornea, and can we blink in response to that? If she was having, like yesterday, our lady with Bell's palsy, she had issues that she was hearing too much, right? So her issues with 7 caused her to lose part of her attenuation reflex. Whereas this lady, the problem is that she's not hearing enough. She's got hearing loss versus the hyperacusis. Okay, so in terms of early symptoms of this of an acoustic neuroma, so we didn't hear anything about tinnitus. She probably has some tinnitus. Sometimes patients will report feeling fullness in their ear. They will have the unsteadiness as their vestibular system has to kind of adjust to the new normal for them. But the big one is the unilateral sensory neural hearing loss, which was definitely what she presented with. And then as it progresses, what's the next cranial nerve that is affected with this tumor? 5. And what was our one cranial nerve reflex that had an issue? Was our corneal reflex. Okay, so remember this thing, so here's 5 right here on this brainstem. This thing grows out here in the internal auditory meatus and then will initially grow up and it will impinge on the trigeminal nerve. Okay, so facial numbness, and then she did say, let's see, she did say she had face pain, right? Yes, there you go, left facial pain. All right, so spared in this case. In terms of that issue with the corneal reflex, it probably wasn't 7 as a problem because she 7 is usually spared as this thing, it doesn't grow into the meatus, it grows in towards the brainstem. And then she had some mild unsteadiness, but she did not report vestibular symptoms. She did not say she was diseased. She did not say she was having trouble, standing up. All right, so here is this an MRI or a CT? What do we think? MRI, okay. And here's another squished pons. The poor pons is really having trouble. There's the fourth ventricle. And then here's a little bit different view. Again, we see the pons and the fourth ventricle. What part of the cerebellum is this right here? There's the vermis. Yep, you see it. And then here is the part sticking into the auditory meatus. And again, is anybody hungry for some fried mushrooms? Because doesn't that look like a little fried mushroom? Lunch, anyone? I'm starving. Okay, so final diagnosis was an acoustic neuroma. The neurosurgeons went in and carefully, this thing was big, dissected it away from the cerebellum, the pons. It was actually touching cranial nerves 5, 7, 9, and 10. So can you imagine getting that off of 9 and 10? Holy cow. I was also around some of the branches of pica. They were able to preserve the facial nerve during the surgery, but just gave it up on the vestibular cochlear nerve and just went ahead and cut it off. So post-operatively, if you chop off the cochlear part of that, you will have sensory neural hearing loss. She did actually get vertigo and nystagmus a couple days after surgery, but that did go ahead and resolve. So good for her. All right, that's it for cases for today. So hopefully that puts some stuff together. I'll be here for a little while if you guys have some questions, and we will dive into eye movements tomorrow. That's all right.